So just to make it clear, this is keratoconus. So the optical corrections, let's start with the basic. Zero. No optical correction required. Just because there is a keratoconus doesn't necessarily mean that a patient requires optical correction. Patient with K-conus can have 6/6 vision. As far as the quality is concerned, quality is something that the patient perceives. It is subjective. So he or she may be happy with the quality in early stages and may not need correction, may not require glasses. So if I detect keratoconus on a routine checkup and patient does not require spectacles, I simply tell them about the K-conus because I don't want them to come after 5 years again with a full-blown K-conus. I tell them that they need to come for regular follow-ups that is required, but not every patient gets an optical correction. So there are subtle red flags for keratoconus. Ghosting complaints. They might tell you that vision is 6/6, but there is a little ghost image, or there is vision fluctuations. My vision at night is worse than during the day. Sometimes there is a mild astigmatism. Patient is 6/6 but not happy. So these patients, especially youngsters, we tend to dismiss, saying that maybe there's a little bit of dry eye, you're doing 14 hours a day on the computer, and we give them teardrops. But we need to look at them on the slit lamp. Most of these you'll be able to detect on slit lamp. If you do autoref yourself, you'll find some changes on the autoref itself. It's not fitting in the usual pattern. For those of you who still remember about retinoscopy and still have a streak retinoscope or a spot retinoscope and do the retinoscopy, which I still do, you'll find the classical scissor shadow on retinoscopy. Many of these are eye rubbers. If a mother brings a child in saying that the child tends to rub the eye all the time and there's not much allergy or nothing like that, I don't know which starts first and which comes later. K-conus patients tend to rub their eyes. Those who tend to rub their eyes develop K-conus or it worsens. And if there is a family history of K-conus. So these are some of the subtle red flags which should warn you that these patients require a closer follow-up. So optical correction, spectacles. Most patients with K-conus have myopic astigmatism, which can be corrected with spectacles, may change the number from time to time if there is advancing keratoconus. As the disease progresses, the myopia or astigmatism may increase. Ultimately, the patient will go beyond the need for glasses. They are not happy with their glasses. So in that case, you might have to resort to contact lenses for these patients. So right from the beginning, if you know that the glasses number is changing, it's nice to tell the patients or the mother at that time itself that we'll try with glasses as long as possible. But to improve the quality of the vision, the patient will need contact lenses. There is a mental barrier in many of our Indian parents to contact lenses being worn too soon in life. They always feel that child ko college jaane do, when the child goes to college is when we'll wear contact lenses, which is all right for cosmetic reasons. But for K-conus, we might want to push them earlier, so start advising them early. So what contact lenses? Initial stages, soft contact lenses may give them acceptable quality of vision, but the go-to lenses for K-conus are the RGP lenses, the rigid gas permeable. Earlier we had only hard lenses, but now we have the RGP lenses. They may feel a little uncomfortable at first. Your optom needs to be trained in the fitting RGP lenses, but they provide excellent vision and can be custom made quite well. You also get piggyback lenses where you have a soft lens on which you put the RGP lens. So this the hard lens on top of a soft one works well. Hybrid lenses in which you don't have to have two lenses, it's two in one. They have a rigid center with a soft ring around for comfort. That patient is wearing a hybrid lens with a soft skirt and a hard center in the center, so that patients who can't tolerate hard will still be able to manage with a hybrid lens or a piggyback lens. And then you have specialized lenses for keratoconus. Out of them, the two common used ones are Rose K RGP lenses. Rose K is named after the inventor, nothing to do with the flower. It is Mr. Rose in UK on whom it is named. So they are custom made for irregular astigmatism, highly irregular corneas. You have these, and they are two types basically. Those which are, if there is a central nipple on the cornea, then you have one type. If you have an eccentric nipple, you can have it custom made accordingly. So you can do a topo, you can send the details, and you can get a customized lens for your patients. I've done a lot of rose scale lenses, but now I've entirely almost shifted to the scleral lenses, which I'll talk to you about. So the features are that they're highly gas permeable, a lot of oxygen penetration. They're fairly easy to insert, remove, clean. And the only thing is that they need re-evaluation. If the patient has got K-conus, the chances are that they may need, because they're customized to the patient's cone, they may need a new lens every year as well, which becomes a little expensive. So in many curves are required, and it's a complex fitting for these patients. The Rose K2, which is the newer one, minimizes the aberrations by applying very small changes to the curves on front and back of the lens. This is going a little technical. I prefer to use now almost exclusively the scleral lenses, both mini scleral and regular scleral. I thank Chandrasekhar Chavan, who worked with me on these lenses for K-conus. So that for scleral lenses, you don't have to change them frequently. Even if the cone progresses, the scleral lens will still vault over the cone, and there will be an area of saline in between the sclera and the cone. So there is a no-touch technique. It doesn't touch the cone at all. So there is a liquid reservoir between the scleral lens and the cone, which makes it very, very comfortable to the patient and improves their vision. For those who are technically minded, it's divided into 4 parts: the central wall zone, the peripheral corneal zone, the limbal lift zone, and finally the scleral landing zone. So we need to know what is the horizontal visible iris diameter, and you can order these accordingly. You can have, as I said, mini scleral lenses, which are lenses up to 6 millimeters larger than HVID, and the regular scleral lenses, which are more than 6 millimeters higher. So this is the true scleral lens. Ideal diameter is about 17 to 18 millimeters. So it's a large lens. You can use smaller lenses for the smaller corneas or a flatter cone. But if it's a steep cone, then you're better off with the regular scleral lens. There is the prolate versus the oblate designs. So for normal corneas or mild K-conus, choose the 16 mm or 17 mm. For more advanced keratoconus, you choose a deeper sag. The initial, so this is what is preferred. Successful lens fit. These are some of the things which go into a successful lens fit. It's a small course by itself on how to fit scleral lenses, but your patients will be very happy with these. So don't jump to surgical managements of these. This is an OCT which shows how much of a lovely reservoir there is between the cornea and the scleral lens. And now with our AI, we are getting 3D printed scleral lenses as well. So you have this iPrint pre-RO design software which can customize even a scleral lens. So not only rose K, but even a scleral lens can be customized to fit all. So this is, as I said, using 3D software. So thank you. Consider optical correction in keratoconus. Reduce dissatisfied keratoconus patients in your practice. Thank you so much.
Thank you, sir, for the informative talk.